Hello, everybody, and we're going to continue the lecture on the human concept in social institutions, and here we're going to focus on the institution related to health and how dehumanization kind of fits into that. And we've already talked about this a little bit throughout this course, but again, I kind of want to break it down into its different elements, and that way we can highlight at what different levels can dehumanization occur. So we're going to focus on the level of the patient as well as the practitioners, and for the patients, we're also going to talk about dehumanization and disability. Now, at a broader level, though, what we can do is we can actually see instances of dehumanization from the three different distinct processes that I've talked about in previous lecture within the health institution. So, dehumanization by default, for example, well, first, some of the studies I talked about in that, especially the Harrison Fisk one, looked at drug addicts as a group that was just not afforded any social cognition, therefore denied humanity. But we can also talk about it maybe at a larger level. For example, the idea that health is often talked about in terms of statistics. People may lose kind of a sense of individuality or personhood when they are just kind of aggregated into a large sum of a group of individuals that might have similar symptoms. Or you might just be another number in a line waiting to receive some sort of service. Then there's also the associative form. We tend to see that certain types of, disorders or ailments might lead more to some type of dehumanization. And we'll talk about that a little bit later. And then there's the functional, and we've talked about this often in the context of doctors dehumanizing patients as well as perhaps themselves in order to engage in some sort of treatments that might be very severe and very hard on the patient, but that is necessary for them to recover. So overall, there's a lot of different instances of where dehumanization can occur. But I do want to focus on the patients and the practitioners because I think this is kind of the simplest way to break it down in terms of health. So now when we focus on the patient, we can look at various aspects of the patient side of the relationship that can lead to some sort of dehumanization or is an expression of that dehumanization. Now one is going to be this idea of de-individuation, and this is going to be this idea that sometimes we're put in situations when we are denied our individual identity and kind of lumped into some sort of group. And this is largely going to be kind of a dehumanization by default thing. So what might happen, especially if a healthcare facility like a hospital is very busy, perhaps it's an emergency room and it's a kind of a party type weekend where there's going to be a lot of, maybe substances that affect our ability to make good decisions, as well as things that might be fun to play with, but also a bad idea to do if you're impaired, such as fireworks. So if it's a busy time of the year for, let's say, an emergency room, and they're seeing a lot of patients, well, you might just be another person in line, and they may try to be attending to as many people as possible in a most efficient manner. And what that might mean is not necessarily kind of attending to you as a person, but as just something that needs to be fixed and kind of put away so they can move to the next one. And we could kind of also understand this just basically any type of situation where somebody is lumped in with a large group or kind of on a list with other people, and they're kind of sharing this similar perhaps ailment or need for treatment. And what this might do is this might kind of decrease the focus on perhaps individual differences that might become very relevant for treatment. So what we might see is that somebody might be complaining that they're experiencing higher levels of pain. Well, that dehumanization by default, that lack of attributing the other person a full human mind, might just kind of downplay the intensity of the pain that they're feeling. Or somebody might have this extreme phobia of needles, and instead of wanting to be injected with some sort of like drug or medicine, they might prefer a pill. However, that may not necessarily be, kind of in the purview of efficient medical care. Everybody gets a shot, that's it. So we might see that in certain situations, individual preferences, desires, or even just sensations in terms of pain threshold might be ignored just because they're just one amongst many. Now, another kind of causal factor that might come into the dehumanization of patients is through this belief of impaired agency. Now, this might be more relevant in the context of, let's say, mental health care, where, let's say, atypical thinking or cognition might be viewed as an impairment and therefore less fully human, and that might be kind of a disruption to providing efficient care or even connecting with patients. But this idea of impaired agency even comes in the context of just regular hospital visits or any kind of like healthcare procedures, where the individual tends to give up their sense of agency for whatever the discretion is of the healthcare provider. And in certain situations, the healthcare provider's desires or wishes or their agency may override our own. You may not be able to get a certain procedure that you rather prefer than the one that you're going to get, or you may not even be able to leave the hospital in certain conditions. So this idea of dehumanization through the denial of agency is going to be kind of this understood under that associative process. Now, a third aspect we can talk about is this idea of dissimilarity and how this can lead to dehumanization. So basically, you are going to be more likely to go to the hospital, like outside of the idea of just normal checkups and physicals, of course, because you don't feel like you usually feel. Or you may have noticed something looks like it's not supposed to be like that. So this might be something like a discoloration, for example. But basically, there's something different going on compared to either your normal state of affairs or how people usually feel, act, or look. And because you deviate from the normal person, you might not be seen as fully human. So what this might mean is, let's kind of take this idea of mental health in consideration. Someone that has schizophrenia doesn't think like the typical person. Therefore, they might be viewed as something other than a typical person, and that might lead to a sense of dehumanization. And eventually what might happen is that the person becomes identified or defined by their ailment. So a person with schizophrenia is no longer a person with schizophrenia, they're a schizophrenic. So what basically happens here is we have this idea, this prototype of what it means to be human, and those that are not healthy, physical or mentally or otherwise, may not necessarily fit our prototype or understanding of what it means to be human. Now, one group that tends to face a lot of dehumanization are those individuals with disabilities. Several studies have found different types of links between dehumanization and perceptions of those that are disabled. Now, one way that we can actually look at perceptions of other individuals that we've talked about in this class is through the stereotype content model. And here, remember, we're kind of talking about how we perceive people possessing levels of warmth and or competence. And what we said before is that it tends to be that when people are denied the concept of warmth, that is pretty much associated with human nature, and that's more mechanistic dehumanization, whereas competence more associated with uniquely human characteristics, and in the denial that kind of leads more to animalistic dehumanization. So from here, we would expect certain types of disorders would be dehumanized based on where they kind of map onto this warmth and competence grid. So some disorders that have been looked at in the context of stereotype content model, things like sociopathy, this is going to be perceived as low warmth but moderate competence. And then there's going to be schizophrenia and addiction that are typically seen as low in both warmth and competence. That kind of discuss quadrant that we talked about with homeless individuals and drug addicts with the Harrison Fiske studies. And if we want to kind of translate that into dehumanization, well, we might often see sociopaths being kind of mechanistically dehumanized, seen more as robotic, and we may see that those with schizophrenia or various types of addiction more in terms of animalistic dehumanization. But a study by Boysen and Chigotska kind of call this into question and shows that the stereotype content model really doesn't actually explain dehumanization in the way that we would expect it to, or at least in the context of different types of mental disabilities. So for example, in one study, they found that the dehumanization of various types of disorders such as anxiety, PTSD, obsessive compulsive, ADHD, depression, anorexia, bipolar, schizophrenia, drug addiction, the level of dehumanization correlated to both scores of warmth and competence, and that was in a negative direction. So the higher the level of these disorders, the lower the warmth and the lower levels of competence they were perceived to have. However, for a different study, what they found is that the disorders related to addiction, autism, and dementia kind of varied significantly across warmth and competence, but elicited the same levels of dehumanization. So here what we're seeing is that the attribution of warmth and competence is not kind of this thing that's going one-in-one with this dehumanization of these disorders. There's going to be something different going on. And they found further support for this when they did actually an experiment where they manipulated levels of warmth associated with addiction and intellectual disabilities. And what they found is that this did affect certain types of attitudes about those disorders, but not dehumanization itself. So what does this tell us? Well, one is that the stereotype content model is not going to be appropriate for understanding the dehumanization of these disorders. There's something else going on. So what this might mean is that these forms of dehumanization related to these different types of disorders may not necessarily be at least entirely associated with the associative process of dehumanization. There may be something else going on. Now, of course, there still might be all the associative process going on. That might be the only thing and it just might not be the stereotype content model. However, it seems like there might be something more than just associations going on. So there might be dehumanization by default. The inability to access the minds of those individuals with these different types of disorders might be causing some sort of separation that might lead to a form of dehumanization, but there might also be this functional form of dehumanization that's going on. So for example, these might be situations where we don't want to attribute a sense of humanity to these individuals in certain types of disorders, such as sociopathy, and that might be a way to kind of ease any kind of guilt for our antagonisms or kind of mainstream or popular negative opinions or attitudes against those with sociopathy. But it also might be a way to kind of protect ourselves emotionally. So for example, those with dementia, well, that might be very heartbreaking for individuals that have seen or witnessed what dementia does to an individual, especially if it's in their own family, or they might be worried about what happens to them in the future. So although there might be this idea of competence informing dehumanization of those with dementia, it might be a protective way to not kind of feel the negative emotions that comes with kind of interacting with an individual with dementia, or the possible threat of experiencing it yourself later down the road. Now, these are all speculative, but I think that's why this idea of the three distinct processes can be very important, because it may help us understand why dehumanization occurs if a previous model doesn't work. Now, a study that looks at some of the effects that occur out of this dehumanization of those with disabilities was conducted by Parker and colleagues and published in 2020. And what they found was that those with developmental disabilities, and in this study they used autism and Down syndrome, well, they were often on the receiving end of this hostile form of prejudice, where there was beliefs that they were going to cause harm to others. So, for example, one of the items in that questionnaire about hostile prejudice was when people with autism or Down syndrome are in public settings, there's always the risk they will harm others. And then there was also this component of separation that they asked about in their hostile prejudice measure. And this had items like people with autism or Down syndrome should spend time together rather than in settings with non-disabled people. And what they found is that for that harm component of that hostile prejudice scale, actually had a pretty strong relationship with dehumanization at a 0.64 correlation. Now compare this to the 0.5 correlation that is usually kind of used as a benchmark for a strong correlation. Now when we look at the separation component of that hostile prejudice measure, we still see a positive correlation, but it is a little bit weaker. It's at a 0.22, so 0.1 is a small or weak correlation, and about a 0.3 is going to be that mid-sized correlation. So kind of in between there, we see the relationship between separation, hostile prejudice, and dehumanization. And something else that they looked at was support for various types of social policies that would benefit those with these developmental disabilities. So they looked at things like support for having special education funding, as well as other types of financial assistance. And they had these reverse item scores as well. And one would be like those with autism or Down syndrome should not be a priority. So basically looking at what type of social assistance we should provide individuals with Down syndrome or autism, or if we shouldn't actually use any social policy to help these individuals. And what the researchers found was a negative relationship between dehumanization and support for social policies that would benefit those with Down syndrome or autism, and the fact that the more dehumanization occurred, the less support for social policies that would benefit them. In a later study in the same article, they actually did an experiment where they tried to individuate or humanize the individuals with Down syndrome or autism, and then they also had them complete the other measures, so the hostile prejudice that I talked about earlier, as well as social policy beliefs. And what they found was that by humanizing or individuating the individual with Down syndrome or autism, for example, talking about them in terms of experiencing secondary emotions, it actually reduced the levels of dehumanization, which in turn then led to the reduction of hostile prejudice and increased support for social policies. So here again, we can see the individuating of individuals and kind of trying to talk about them more humanistically is going to lead to better outcomes for them. Now, within the context of dehumanization in the Health Institute, let's kind of look at this idea of practitioners. And we've already talked about some of this before, but let's try to put them all together to kind of provide a bit more of an elaborate understanding. So medical practitioners are going to engage in dehumanization against patients as well as themselves for a variety of reasons. And we talked a lot about this in the context of the functional perspective. And we can see this in the first 2 points here with empathy reduction and moral disengagement as kind of reasons why doctors would engage in some form of dehumanization. So we see this especially with doctors that, treat patients that have some sort of terminal illness, that it's going to be much harder for them to kind of do their job if they're very emotionally invested with their patients. So what they might do is either kind of dehumanize the patients by not acknowledging their, pain, sensations, or those types of experiences that they might have that might be kind of associated with a sense of suffering. But they might also kind of dull their own emotional responses to individuals, kind of in effect, mechanistically dehumanizing themselves. Then with the moral disengagement part, allows them to kind of engage in these types of treatments that would otherwise be seen as very cruel or very severe. So this might be things such as open heart surgery, or even something kind of what we would see trivial as giving some very foul tasting medicine. So both of these kind of try to, disrupt the link between the patient suffering and then the doctor's suffering, but they're kind of done in different ways. With the empathy reduction is trying not to kind of feel or experience what the patient is feeling, and for moral disengagement, it's more about kind of being able to do things that would otherwise be seen as, not okay or not acceptable, but it is so in a kind of medical situation, and also in the context of saving the other person's life or making their life better in some sort of health-related way. So these are both kind of functional forms of dehumanization. Now, mechanization can also be a form of a functional dehumanization, but also might be associative. And I think this is going to kind of be one of those things that really tries to test the boundaries between the associative and functional. So what I mean by mechanization, I mean that a doctor is going to be treating an individual with some sort of illness or ailment. And basically what it's looking at is almost kind of like car repair, if you will. Okay, if there's some sort of issue that you have with your car, let's say the engine is not starting, well, they're going to look at all the different parts of the car, how they're supposed to work, how they work together, and see what part of that car is going to be kind of malfunctioning. And then they're going to fix that part and then move on to the next car. Well, for doctors, they're going to do something similar. If you are not feeling well, they're going to try to find what part of you is malfunctioning, try to fix it, and then send you on your way. So in this way, doctors could be seen as human repair people, and that you as the patient, or whoever's the patient, is being seen as an object that needs to be fixed or taken care of. So this could be associative because, well, you're being associated with something that needs to be fixed rather than just a person. You could kind of think of the TV show House, where they're trying to come up with all these different types of diagnoses to understand what's wrong with somebody. But then you can also understand this in the context of the functional perspective in terms of viewing you in terms of something that needs to be fixed and, consisting of a variety of different parts that have their own functions. Well, that might be a functional way to actually help treat the individual to get them better. Now, an article by Hake and Waits, they argue that this kind of mechanization is going to be more of a functional form of dehumanization, and I definitely see that as kind of the situation and kind of how it was presented as a way to try to isolate certain types of bodily issues or perhaps cognitive or mental issues, and isolating on those and trying to fix that and then moving on to the next. But I do think there is an associative process that might also be occur, so you can have that debate amongst yourselves. Now, I was actually going to talk about anthropomorphism and consumerism in here, but I think I'm going to save that for a separate video, and I'll have that one right after here. So I'm going to leave it here for now for the social institution of health and how it relates to dehumanization, and I'll see you in the next video.